Okay, then yeah, hi everyone, and hi everyone online. This is the third event of the seminar series, which is happening every 2 weeks, and we will have today Ricard Gavaldà, who is working in Amalfi Analytics, basically the CEO, and a professor at Universitat Politècnica de Catalunya. Just before we start, some housekeeping. For the people that is attending in person, please register on the tablets. Then all this webinar will be recorded. If you have any concerns about that, please let us know, and we will remove your face if we can from the videos. Once it's recorded, we will upload the webinar online. If you are online, please mute yourself. If you, for some reason you can unmute. At the end, we will have about 10 minutes, 15 minutes for questions. If you are online, use the question and answers functionality or the chat, or put your hand up at the end, and we will give you the word. Today we have Ricard Gavaldà. He is a co-founder and CEO and scientific director at Amalfi Analytics. He is also a professor of computing at Universitat Politècnica de Catalunya, although he is on leave since he started the Amalfi company. He is also a member of the entrepreneurial advisory group on real-time analytics from big data, which is an initiative by the government of New Zealand. He's a member of the board of advisors at Kivist Analytics and a co-author of the book Machine Learning for Data Streams with practical examples in Nemo and more. And he will be talking about the company that he's the scientific director of, and basically topics on machine learning and complex patterns analysis for healthcare systems data. Then, without further ado, let's give a round of applause to him to welcome him.
Wait until the end. Let's see.
Let me see if I can stop, and you can share your screen, Ricard.
Right. Share screen. Okay. Okay. Can you see it correctly?
No, I can see the presenters.
Okay. Yes.
And how can I do this bigger, or is it fine?
Focus on content.
Yeah, perfect. Yeah, if you want to start, we are here to hear you.
Thank you. That's me again. I will go over it. I should have added here something that may concern you. I am also the co-organizer of a workshop in data science for social good, which has reached its 10th edition. It's associated to ECML. So just to tell you that I do care about the social uses of data science, and also I'm sure that many of you do, so please consider that workshop for submission. I can give you information offline if you are interested. Anyway, thanks, Mikel, for this invitation. Thank you all for being there. I'm really happy to tell an audience specific on digital health about the project that has been taking my efforts for the last easily 7 years. And besides this bio that Mikel pointed out, I want to give you a little bit more of perspective of why you find me doing these things right now. So I've been working at the Technical University of Catalonia doing machine learning for the last 20 years. I was a pure academic. I enjoyed a lot my job. I enjoyed a lot teaching. I enjoyed doing research. But it's true that, and honestly, I thought that I would retire as an academic. That's what I would be doing for the rest of my life. But, you know, life had other plans for me, and these plans appeared in the form of Dr. Juliana Rivera. She is really a force of nature, a very non-standard doctor, very non-standard in that she is very much digital and numeric, but also in that she has not been that much in front of patients, diagnosing and treating patients, but basically holding management positions, both in hospitals, rearranging processes, at primary care, caring about how we deal with chronic complex patients. At the Catalan healthcare service, Catalonia is the region where we are. It's a part of Spain with about 4 million inhabitants. And in Spain, healthcare is very decentralized. So she had been at this central agency caring about how resources are placed in the various parts of the territory to better deal people. And she started telling me when I met her in 2014, actually, 2015, about problems in healthcare that I knew very basically nothing about. I thought of healthcare as AI in healthcare, in precision diagnostics, in all the omics, image processing, etc. She told me about other kinds of problems, which I will tell you about. We started thinking about what could we do about these problems from the university. But at some point, it was the university itself that pushed us to try to commercialize something related to that, because it's simply too difficult to have an impact, like a real impact from university. So they told me about, you should create a spin-off. This means you have to create a business plan and maybe care about investment. We said, wait. What's a spin-off? What's a business plan? What do you mean by investment? We really knew nothing about all this world, and I had never thought of becoming an entrepreneur. But somehow we did it, and we had to learn about all these concepts the hard way. That is by making mistakes. I am super happy of the team that we have created. There's 10 of us right now in Amalfi, particularly the technical team, which is 5 people at the moment. Other people have passed by, and that's really the main asset we have right now. So just to tell you that I'm still a bit surprised of finding myself being CEO of anything, with the additional experience that in December 2023, so about a year ago, we, Amalfi Analytics, was acquired by the Reliance Group. I tell you about this because it has an impact of what we are working on right now. Reliance is initially a French mutuality based in Lyon, who is at the core an insurance company, a very specific insurance. They insure hospitals and in general healthcare systems for civil responsibility. That means suits for malpractice, for medical errors, even for things like cyber attacks, etc. So at the personal level, this has been an extra experience for me, becoming the CEO of a small 10-person startup to being part of a pretty large group and having to learn to navigate the complexities of a large group. And for Amalfi, it has meant something else, which is we were putting emphasis on efficiency, as you will see next, and making healthcare, making better use of the resources in healthcare. But we are finding ways of also making, for example, hospitals safer places, because that's what aligns with the goals of this group that we are now part of. To give you an idea, they basically have the monopoly of this area in France, and they have substantial parts. They are insuring substantial parts of the healthcare systems of Spain, Germany, Italy. They are now entering Belgium and Portugal. and their aim is to become pan-European. Not in the UK yet. It might happen at some day. Okay. At the moment, it should be now. Sorry, I didn't change this. I used this slide from another presentation. At the moment, we are present or have been working with close to 30 hospitals for our solutions. Not all of them have become customers, but from all of them, we learned to provide a better solution. So what do we do? And what is what I'm going to talk about? I'm going to talk first about the big problem that healthcare has. That is what Juliana, my co-founder, told me, and that led to the definition of what Amalfi has to be. I'll tell you about the approach we take compared to other startups which do other kinds of things with machine learning in healthcare. I will talk, and that will be the bigger part of my talk, about the two platforms that we have built for different aspects of healthcare using machine learning. One is mostly supervised machine learning. The other one is unsupervised machine learning. Then I'll tell you some insights of my experience of what it means taking machine learning knowledge from the lab to the hospital. And then I'll wrap up saying why I still, after 7 years closely of working on this, think that our approach is not only a key one for the survival of healthcare systems, but also the easiest and natural one to start introducing AI in hospitals. Okay, so what is this big healthcare problems that healthcare is facing? Well, right now, 23 of the Europeans are over 65. In 2040, that will raise, that will go up to at least 40%. Okay. Aging brings complexity in the form of chronic disease. Chronic disease across Europe is already taking 70% of the expense. Okay, so you see that it doesn't scale. If elderly people is going to double, then well, this is more than 100% of the expense. In a situation where it's not likely that the resources for healthcare are going to be growing at this same rate. Not only because the expenses will not be there, but because aging also brings additional expense in the form of pensions, in the form of social care for elderly people. So it's not just that politicians not wanting, but there will be simply no funds for that. Right now, healthcare is more than 10% of the GDP across Europe, and in particular, more than 20% of the public expense. Okay, so we have a problem unless we change how we are delivering healthcare. The very survival of the pillar of the welfare society that is healthcare is really threatened. So we need to do more with the same resources or probably fewer resources. How can we do that? There's several ways, of course, but there's at least two ways. One is to reduce the burden of low-value tasks. That's where things like chatbots, like telemedicine, like automating processes, billing processes, etc., fall in. That's certainly very important. That's where automating the work or supporting the work of some types of clinicians also enters. And for example, the idea of reducing the time that a radiologist spends analyzing an image because it has the help of an AI that's something in which I really believe. Okay. The other way is reducing the enormous waste of resources using already existing data. Okay, and believe me, there's an enormous amount of waste going on in healthcare. I list some of the issues on the right. The waste is not there because the people that run the system are stupid. It's because the system is more and more complex, and no matter how genius you are, you cannot have in your head everything that goes on and reduce all the pockets of inefficiencies. Of the list I have on the right, my favorite is maybe the fifth one, which is useless medication. Did you know that 30% of the medication we give in hospitals, particularly, I have the statistics with hospitals. I'm sure that in primary care, it's about the same. 30% of the medication we give, we could not give and nothing would happen. The patients would not be better. In fact, they might, in fact, be better because extra medication means additional adverse effects. So then we have to spend money on fixing the problems that the medication created. Okay? You still with me? Sometimes when I don't see your faces, I wonder if the connection went down or something. Yep. Hello?
Yeah, sorry, I muted myself, but yeah, everything's fine. Yeah.
Okay, good. I really wish I could be there with you. I had more time to come because I really don't like giving online talks. I'm a teacher by nature, so I like seeing the faces of the people I'm addressing. But anyway,
Yeah.
that's what we could do.
You're invited. You're invited.
Yeah. Okay. Let's talk about that. Okay. So what is the way that we chose with Juliana, with my co-founder, for Amalfi? Okay, we are going to use data that the system already has, especially data that is easy to extract, that all hospitals want to have, plus the right machine learning algorithms to create efficiency, to make sure that the resources are placed where they matter and not where they are wasted, to increase the quality of care, that is making patients healthier, and also make patients safety. That is, we want to reduce the risks that are in fact created by the healthcare system. Okay, in case you didn't know, hospitals are an extremely risky place, extremely dangerous place. So don't go there unless you actually need to go there. Okay, we want to create well-being for the staff, and this is a key point. Maybe if you are around the healthcare, you've heard every talk here. Let's put the patient at the center. Okay, do you have this sentence there in the UK? And what I always say is, okay, the patient is not put at the center magically. It's the people that assist the patient that put them in the center, and these people need to be in good mental condition, need to be able to do their job in the right conditions. So because we ask a lot from them, we ask them to be implicated, we ask them to work safely, we ask them to not make any mistakes, we ask them to use the right resources we give them to them, and not only that, we ask them to help us with a smile on their faces. And that can only work if they are not burned out, if they are not overworked, if they have the right conditions, the right resources to work. And then I will talk that a little bit about at the end. This formula is the one that guarantees scalability of our solutions to a lot of hospitals. I mean, we all agree that AI is the future of the healthcare. So why is it so slow to penetrate? Because we often design solutions that are not scalable. They are designed for one hospital because of the silos they have that should work differently in some other hospital. Okay, and also because the closer you get to the patient, the more the ethical and the legal complications, the bigger they are. So what we want to do is solve problems that affect a lot of the patients, that impact on a lot of the patients, that can be implemented easily, no big problems with the silos, and that also do not have the strong impact on, for example, on patients, such as, for example, personalized diagnostics or recommendations for every individual patient. Okay, what do I mean by administrative healthcare data? It's something like this. This is really a fake. But there is this sort of universal standard called the minimum basic data set that takes slightly different forms in different countries, but it's recommended by the World Healthcare Organization for statistics, and also used by the governments for billing. Okay, what is this minimum basic data set? I did not do my homework, and I don't know how it's called in the UK, but surely every hospital is computing an Excel file like this. Okay, it has a column which is, let's say, some patient ID, sex, say year of birth or age or something like this, some geographical indication of where the patient lives. And this is for hospitals. There's different ones for, say, primary care, arrival time, where the patient comes from their home, from other hospitals, from it's a referral from primary care, discharge time, and how this patient was discharged, home, or a patient died, or sent to another hospital, or the patient escaped without, let's say, the approval of the doctors. Okay, these are the most common codes that you find there. And then the key part is you have a list of diagnostics. If you know ICD-10, might be a list of diagnostics in ICD-10, and then a list of procedures performed on the patient during their stay. Also, for example, ICD-10. Okay, these, in case you don't know ICD-10, these are this is a list of all the cataloged diseases that people might have. It has over 70,000 codes right now. And for example, E11.91 is some form of diabetes. F41.0, I don't remember, it might be something like chronic kidney disease, things like this. Okay. Now, in most countries, every hospital has to extract this, for example, once a month and send it to their government, or they're paying for billing. The government takes these minimum basic data set, perhaps uses some aggregators such as DRGs. If I was there, I would ask if you know what DRG is. DRG is a way of putting one such episode, one such line of this Excel file into one box, to which a payment is associated. So, for example, the DRG for one episode might be chronic heart failure. Okay, and the government say, I'm going to pay you £2,000 for every episode of chronic heart failure. I'm going to pay you £500 for a normal delivery, but £1,000 for a delivery with a C-section. Okay, this is modulated. This belonging to a DRG is modulated by not the main diagnostic, but a little bit by the length of stay and the procedure list, etc. Okay, the idea is that there is this data that every hospital already is extracting from the information systems. And basically what we do at Amalfi is, okay, hospital, you know that Excel that you extract once per month. Now please extract it once every day, every month as well, maybe every 15 minutes, it depends on the application, and send it to us. Oh, the hospital says. So you mean like the same query that I execute once per month executed here? That's what you need? Yes, that's what we need. No long processes of getting complicated data. That's one of the keys to our approach. Okay, and where do we want to go? I will go quickly on this one, but we want to help people with at the micro level, at the meso level, and at the macro level of healthcare. We want to be everywhere, and we want to help both the large hospitals, but also the primary care facility at a small village somewhere in the countryside. Okay, let me go to the two platforms. So we have a predictive platform, which is basically to support operational decision making in hospitals, and an analytical platform which is to support population healthcare decisions. Okay, what does the predictive platform do? It basically takes this basic activity data from the emergency department and from the wards, basically, and helps, it predicts the activity that is going to happen at the critical parts of the hospital, what resources would be needed for coping with that activity, and also predict what kind of resources you're going to have to be available, okay? And the goal is to be able to anticipate issues rather than react to them. Hospitals are really dealing with, say, congestion periods reactively. Let's give them the time to know in advance what is going to happen and prepare for that. Okay. Right now we have basically the predictors at the red lines. The predictors in red. We started with the emergency department. For them, we predict influx, so arrivals, classified by severity or by type of patient, the occupation of boxes. All these are different horizons from the next hour to the next month, for example. Okay, how many of the people that you are getting at the emergency department will be discharged to other centers? That's important, for example, for making sure that you have the right amount of ambulances, and most importantly, how many of the people coming to emergency departments are going to go through surgery, through urgent surgery, and through hospitalization. That is, how many beds you're going to need up in the wards, okay? Because the people arriving from emergency departments competes for surgical areas, for operating room slots, and for the beds with the people arriving from the waiting lists for programmed surgeries. Okay, you see, I put the programmed surgeries in red. You might tell me, well, this should be in black because you know how many programmed people you have, right? Well, in theory. In practice, the programs change all the time, and surgeries are canceled, and additional surgeries are added, and people are moved from one day to the other. So, in fact, we do have to predict also, other than for tomorrow, let's say for next week, how many people will be coming to your surgical area from the programmed waiting lists, okay? And at the wards, we give them how many available beds they're going to have soon, and discharges. Crossed with all these, perhaps the most important resource, how many human resources, how many nurses, mostly clinical auxiliaries you're going to have, and does that match with what you're going to need with cope with all this activity? Okay, hospitals allocate human resources using roster programs, but there's always a substantial amount of absenteeism, going from 5% to 15%, depending on many things, and having 10% less people than you expect on one day at the emergency department is really the difference between being okay or being in chaos, okay? So being able to foresee that at different horizons is the difference between having congestions at all of these places without warning, or being prepared by moving resources, human resources, and other, and anticipating the impact on the patient and the impact on the human, on the people, on the staff that you're going to have. Just one screenshot. This is currently the look of the influx and hospitalization requests. This is for 1 week ahead, and you see the people arriving At the top, you see the people arriving of low and high triage levels. All this can be configured for every specific hospital in several ways, okay? And let me talk about the part of human resources and actually why this insurance company that bought us is interested in our products. Because they know it's their business. They have these all actuarial experts that, for example, additional waiting time at the emergency department impacts on claims, which is their core business. So this is from a news in the Le Monde newspaper that basically says a study indicates that every night spent in the emergency department on a stretcher increases mortality by 40%. That is a lot. For them, this translates to number of claims, number of times they have to go to court, and therefore money. Okay. Another example, we know, and it's really quite amazing to see how sharply the increases. Every increase in the ratio of nurses to patient translates to more medication errors, attention errors, more complications in the patient, etc. So we want to make sure that the hospitals know in advance how many people will be needed at every place, because that reduces errors significantly. Okay. Some technicalities. I don't know how much of you are technical there. Basically, what we do in this platform is time series prediction. Yes, but time series prediction, which in some cases is enriched by additional information. For example, if I want to predict the influx, the arrivals 1 month from now, all I have is the time series. I have the trends, the amount of things, the seasonality, whether the day 1 month in advance is going to coincide with some holiday period, things like this. But if I want to predict, for example, hospitalization, how many beds I will need at short-term horizon, I know that many of the people I want to hospitalize are already in the emergency department, so I can use information about these specific patients, why they came, and what's their status, and maybe even some previous history, to have more accurate information about the probability that this person is going to be hospitalized, and therefore contribute to the prediction of the time series, to the aggregate prediction. Okay, it's a lot. I mean, we cannot use the standard performance metrics such as MAE or area under the curve, because really we have to understand what the customer wants of the predictors to make the prediction. For example, they really don't care about knowing that tonight only 10 people will come to the emergency department because they know they can cope. They are instead interested in knowing with high precision how many people are going to be receiving tomorrow at noon, because that's the peak time. So if I get, I don't know, 30 people tomorrow at noon, I'm okay. But if I'm going to get 45 people, I'm in big trouble. So that's that's what kind of metrics we need to use carefully. The predictors are not like super complex. I tell you, when they ask me, "Oh, what is your secret? The predictions?" Well, we use ensembles. We use gradient boosted trees. Nothing that magical. What is complicated and what is really the difficulty of the complexity of the problem is everything around it, so that we can customize, say, the predictors quickly to every customer. so that we are ready to add candidate features to this specific hospital. Because they are important, so that we are prepared to deal with communication faults and errors in the data without catastrophically failing. And actually we do all this, and that's where the most effort has been put in having a infrastructure to continuously train and test and choose automatically or almost automatically the best configuration for this patient right now. For example, in terms of the ensembles, we mix features and predictors that pay a lot of attention to the historical averages. Where March 18th today, how was the hospital in March 18th in the last 5 years, something like this, okay? But mixed with predictors that pay attention to what's happened on the last week and what's happened on the last month, for example, okay? And balancing all these kind of in an automated way is really the most complex part of all these platforms, okay? Let me talk a little bit about the analytical platform for population health, okay? The idea here is governments, hospitals, primary care organization do some amount of analytics, much less than they should be doing, I think, on the activity they need, they perform, sorry. So how did we deal with these patients? And then they put plots about percentage of activity dedicated to people with diabetes or to this other disease, or number of transplants performed, etc. The idea behind this platform, in essence, is the activity we do is different from what the patients actually need. And it's much harder to know how we should be treating the patients as opposed to how we are actually treating them, because we don't have the registered data. So we have to have tools to extrapolate from how we're treating them to how we should be treating them. So in other words, we want to have tools for understanding how patients really are, and not only why they come to see us. Okay. By the way, Michael, I see that we are almost there. I try to go fast, so in 5 minutes I'll try to finish this. And the idea is, with the few resources that we have, which are always small, try to focus on the patients at highest risk, or the patients that have higher needs in some way, and focalize the resources there. Okay. So the analytical platform is an exploratory, not a prescriptive tool. It has basically 4 algorithms in it. One is a new patient clustering algorithm that came from actually a PhD that I supervised at my university. Another one is an association explorer, let's say correlation analyzer, a little bit on steroids, using, if you know the algorithms on frequent item set analysis. Another one, this simple statistics for comparing the characteristics of populations, and another one for analyzing patient flows in the territory mostly. Okay, how people move across the different resources that the system has. Okay, I'm going to focus on the clustering algorithm. You'll see pictures like this one. The idea is the idea is this is the clustering of a population such as people with chronic heart failure. The 4 columns are the 4 clusters that the tool found in an unsupervised way by using the diagnostics as variables. Okay, and you see that different clusters differ in the prevalence of different diseases. And we've had quite some successes in analyzing different types of situations at hospitals, mostly by simply redoing this type of analysis again and again. Typically, the clinicians say, okay, cluster number 1, I understand. Cluster number 2, I understand. wow, look at cluster 3. I didn't know that we had so many patients with these profiles, and I had no idea that they died twice as much as other patients with the same main diagnostic, and that they come back for readmissions 3 times more often than the rest. Let's focus on this. It's only 10% of the patients, but if we can manage to reduce these statistics for these specific type of patients, then we are in good shape. Okay. I will send you the slides. You can look at what the clustering algorithm works. It's based basically on tensor decomposition, no k-means or no hierarchical algorithm. Just to give you an idea of the kind of use cases that we've had is which are the patients for one type of pathology or for one type of surgical intervention that get more in-hospital complications. So, for example, more infections or more anemias or more hemorrhages after the intervention. The idea would be focus on this small amount of patients on prevention actions. Okay, another one is use cases for deviations of key KPIs, such as length of stay deviations. If you can reduce these, you save bed days in the hospital, which is, of course, one of the main costs, or focus on mortality, or focus on readmissions, for example, as I mentioned. Adjusting admission protocols. This was a fun case in which the cardiology department and the internal medicine department fought over patients. They said, you are sending me patients that you should keep and treat, and instead you have some patients that I should be dealing with, because they're more complex, etc. And by looking at these clusters, we gave them a common landscape, a common map of how all these patients were, so that at least they had a common language on which to sustain the argument about who should be treating each patient. Okay. A project I'm super proud about, because I'm pretty sure that in the UK you've done these things already, but in Spain, aging, as I said, brings extra needs for healthcare, but also extra needs for home care attention, social care. That is not a nurse going to this patient's house, not a doctor going to this patient's house, but someone to help with doing the groceries, with cooking, with taking a shower, with even just helping this elderly person who start to have mild cognitive problems take their medication, because they have 10 pills to take and they are incapable of remembering when to take each pill. Okay, so this is in Spain. This is rather than by the healthcare organizations, it's taken care of by the city councils, let's say. Okay, so we did the first, and we're working on a bigger problem of actually, for the first time, I think in Spain, integrating the data of both worlds, social care and healthcare, and making sure that these two worlds, and they are truly distinct worlds, talk to each other about which are the most important services that should be given to each type of patient. This is something that everybody knew had to be done for the last 20 years, because the social conditions of healthcare are super important for predicting the evolution of patients and taking good care of them, but nobody was really doing. So that's again a source of pride. Okay, a few insights from the difference of doing something in the university lab to actually building a product that can be put and sold to many hospitals. A lot of the things we did is due to the fact that we are a very small team for everything we needed to do. So we decided on a number of policies. We try to make as little distinction as possible between the data scientist and the software engineer and the DevOps. we try to ensure that everybody knows a little bit of everything to some extent. This is also an insurance, because if in a team of 5, if 2 people leave, you're dead, and people do leave. So the knowledge has to be as distributed as possible. Okay. Also, there is this rift between the data scientist that creates a complicated model and then gives it to the software engineer that has to put it in production. If they are different people, or if they don't really know each other's work, the software engineer puts a model in production but doesn't understand what it does, and that's really a recipe of disaster when anything goes bad or when the model has to be changed. So we took kind of an extreme programming approach. We do pair programming. Always 2 people are working together. One is watching over the shoulder of the other, and we try to rotate pairs. Having tests before the code is key. We make sure that whenever there is an error in production, an alert is added to the alerting system that we have. And this last one is more a wish than actually we do together. We do systematically, but the idea is once a task had been performed 3 times manually, it's time for it to be automatized. Okay. Everything customer specific is in the metadata, and as we say it, we want to grow the technical team only independently of the number of customers. The commercial team has to grow proportional to the number of customers, but not the technical team. We say it should be O of 1, if you know what O of 1 means. Okay. So to wrap up, we still think that the management problems are the easy way for AI in health, for what I said, because we deal with easy data so that we can deploy in days, not in months, and the ethical and regulatory concerns are much lower than if you try to make personalized recommendations. And what we find is that the impact is visible in a very short time. Not so much impact in terms of fewer deaths, but in terms of, wow, my life as a professional, my life as a service manager, as the head of emergencies or as the head of cardiology has become easier all of a sudden, and this brings to faster adoption. And I could go on for another hour, but maybe let me stop here. And I'm super happy to take any questions now or later or when you want. Okay.
Yeah. Okay. Thank you. Yeah, it was very interesting. Thank you. I have some questions, but I will leave the floor to other people that may have questions. Yeah.
Might be heard.
Yeah. Let me know if you cannot hear the question, and I can repeat. Or.
Hi. I just spilled coffee everywhere, and that's on recording. Wonderful. Thank you. So I guess not finishing my coffee. I was wondering if there have been any instances of multiple hospitals in the same sort of group using your predictive platform for collaborative resource sharing. So, for example, here we have a couple hospitals that work together, and if one is overrun, ambulances will be diverted to a different hospital.
Yep.
And I was wondering if your platform had been used or would potentially be used in that area.
Yeah. That is our dream. We have not really managed to do this, but we had a partial success because obviously hospitals can work together if they work as a network. Okay, so we are ready to put an extra layer on top of the predictions for every hospital to predict the global expected, for example, influx to the whole of the emergencies areas of emergency area of the emergency departments in one area, so that maybe even, and that's a project we have already proposed, it's kind of on hold, even the ambulance service knows in advance which will be the least busy service in an area and take the people there. Okay, take one particular person that needs the emergency department there. There is another benefit of having, say, consortia of hospitals working together, either of the predictor. Okay, in either of the platforms. I'm thinking more of using the analytical platform for what's called benchmarkings. That is comparing fairly the results at different hospitals so that each hospital can learn more about the others, about best practices about the others. And I give you one example. Right now, there are tools for benchmarking which compare something as easy as what is the average length of stay. That's a case we worked on. What is the average length of stay for a patient after one of the most impactful surgeries, which is the hip replacement or the knee replacement surgery, okay? And we saw that hospitals that were somehow demographically comparable in the sense of size, in the sense of they were around the metropolitan area of Barcelona. So in principle, you should expect similar length of stay after the operation. One had 4 days of post-surgery hospitalization. The other had 8 days. Okay, we helped the area find out why this difference, and one was because it was interesting actually. One was because it had a bigger hospital next, so all the complex patients went there, and this became very clearly visible when we actually clustered these patients. There were clusters of patients, joint clustering. Yeah? There were clusters of easy patients that only had arthrosis in their knee, so they had to be replaced, and other patients that had another good number of conditions. So it is to be expected that people in the more complex cluster stayed longer. And we found out that the people that the population that went to the 8-day hospital actually got many more of the people in the complex cluster than the other one. So just looking at the length of stay is not fair for the hospitals because one is taking much more complicated patients. But if you know that, you can maybe reduce the flows or at least evaluate the hospitals more fairly for their performance. Okay, I went a little bit aside of what you asked, but definitely my dream is to actually work with all the hospitals in a big region, Catalonia, where we are, and tell them how the activity is going to be across the whole region all at once.
Yeah, thank you. Any other questions here or online? Maybe I have a bit of a technical question, which is about the time series models. Two questions. One, do you consider anomalies or some anomaly detection? And second, do you use kind of online learning or do you retrain models after some time? You just train a new model?
Okay. We don't, so far, we don't consider anomalies explicitly. We don't say that, we don't say this was an anomaly because normally the anomalies are used at the times. We consider them implicitly. For example, we don't use data from the COVID period or from after the COVID period, okay? And these, right now, we're still doing a little bit manually, not excluding this period, but in no time, it should be this autonomous learning system that says, look, if I add to the training set the data from 2020, actually the performance degrades. So let's exclude that period from that, okay? And absolutely, it's all autonomous retraining. we don't train once, but we are actually training something like every weekend. Okay. What we do related to the anomaly detection and the retraining is we are right now incorporating confidence intervals so that we can tell the clinician, look, we are predicting that you're going to have 100 people arriving tomorrow, plus minus 20 or plus minus 5. And that's very important because if they have to make a decision on changing resources, for example, hiring less for fewer people, maybe they want to wait a little bit more until the certainty margin is narrower. Okay, we do have the alerts in place for really bad predictions. We are not using them right now, just because we don't have the power, enough hands and brains to do something after each anomaly. Okay, but certainly at time we should try to catch the really bad predictions, investigate them one by one, and to find out if it's just bad luck because there was a big storm that sent a lot of people going to the emergency department, or if it's something that we can learn to and add to our predictors.
Mm-hmm. Thank you. Any other questions? Online, we didn't get any questions. No?
I was to say, could you add things like the weather, extra model, extra?
Yeah.
Just generally available effects.
Yeah, absolutely. We did try with weather. So actually, we always get this question: do you use weather, and do you use city events such as the final cups or the Olympics or something like this? Regarding weather, we did try. In general, we don't use it because in large urban hospitals, it makes little difference. To give you an example that we found, it was the difference between being 93% accurate in the influx to becoming 93.5% accurate. So for that, it's not worth adding any complexity to the either model, or more importantly, the complexity of getting the weather predictions from somewhere else. But we did do a test in a hospital in the Pyrenees area, that is the mountain at the border between Spain and France, which sits at the bottom really of the ski tracks. So in winter, the difference between the weekend where the ski tracks are open and when the ski tracks are closed is really essential. And there, for example, the influx predictions was only 80%. It was partly for that and partly because it was a smallish hospital, and the hospital, of course, the lower percentual accuracy we have. But in that particular hospital, it might have been worth adding the weather, for example. Okay?
Yeah, just one point. Maybe you are not incorporating weather, but probably you are looking at seasonality, like the time series. Absolutely. And seasonality, yes. which is not predicting the weather, but probably the winter is different than summer. We have a question in the chat as well. How do you handle drift, data drift?
Data drift. Actually, drift is I had it in one slide. I went quickly. We deal with drift basically by retraining every weekend, as I said, at least once, and making sure that if there is substantial drift, we train even more quickly. So it is kind of an adaptive drift. Actually, my best cited paper was about handling drift in this adaptive way. In times where there is no change, no substantial change, you want to pay more attention to the historical means. In times where things seem to be changing, we want to pay more attention to the recent data, to the recent trend. And that's related to something I said quickly. You remember, we use ensembles with different predictors. One of the simplest predictors is say the same as yesterday. And for things like absenteeism, it works surprisingly well. It's difficult to beat that predictor, because how many people will show up tomorrow to work? Basically, not only the same amount, but the actual same people that showed up today. Okay.
Yeah.
So we have the same infrastructure for handling drift for all predictors, but automatically this simple heuristic will get much more weight in one cases than in the others. Okay.
Mm-hmm. Okay. Thank you. There's a huge question
okay.
now.
There's another question. Yeah.
I wasn't expecting that.
Let's see. Training a model, do you penalize over predictions in resources? Yes, that's very recent development. We try to ask hospitals how many over prediction errors they are willing to pay for an under prediction error. Okay, because that says, okay, over predicting has a cost in terms of extra resources weighted. Under prediction has a cost in terms of extra stress, because I was not prepared to that. We are ready to do that, but I tell you, when you ask such kind of questions to hospitals, they say, "Huh? I don't know. Well, what are you asking?" I mean, it's difficult to get kind of a definite answer that you can put in the cost function for that.
Okay.
Do you know what I mean?
Not completely myself,
okay.
but probably
okay.
I was more concerned about the time.
Yeah. Okay.
But hopefully people understood what you meant.
Yeah.
Yeah, just that we are overrunning the session. Yeah, I would like to thank you again for attending, and you are invited here in Bristol at some point. We can handle that offline. But let's give Ricard a round of applause again.
Thank you.